Good afternoon, everybody. Welcome to the 98th session of e-NISCHIT. And we welcome all our ART centers who have logged in from, we have today ARTs of Andhra Pradesh, Tamil Nadu, Assam, Arunachal Pradesh, Manipur, Meghalaya, Mizoram, Nagaland, Tripura, and Sikkim. And welcome to all of you, and thank you for joining us, taking out time and joining us. Today, the case that we will be presenting in this e-NISCHIT will be an extrapulmonary case of TB among a PLHIV presenting as Psoas Abscess. We have discussed similar cases in the past, but because of the frequency of these cases, repeated discussion of such cases is actually very important for reinforcement of guidelines. So, and it will be presented by Dr. Prapa. Dr. Prapa is a medical officer from SSKM Medical College, Kolkata, West Bengal. Welcome, Dr. Prapa.
Thank you very much.
Before I proceed for the case, let me introduce my colleagues. On my right, I have Dr. Lokender. Dr. Lokender Kumar is a senior TB physician in NITRD, and he is among the very senior people in the field, and we are indeed fortunate to have him here. Welcome, sir. Then I have Dr. Jyoti on my right, who's from Share India, and I also have my friend from Nitin from Echo India, who is behind the scenes and who makes all this possible. So with this introduction and welcome to the session, can I please request Dr. Prapa to make her case presentation?
Good afternoon again. As I have already said, I have presented with e-NISCHIT previously, and I have had a wonderful experience of learning. This case specifically was noted by me in December 2021. So by this time, the scenario has changed completely. Yet it was a very interesting case according to me. So I even spoke to Dr. Jyoti regarding this, and she said it's okay, we can go ahead with the case. This specific patient, he came to us with ICTC positive report. So we just took the patient and we started on ART from ART center, that is in December 2013. And he was found to be having cervical, axillary, and inguinal lymphadenopathy. Then we found out that he had already shown this to Howrah Hospital, and as Howrah is a nearby district from SSKM, and he was started on ATT from there itself. So Uluberia dots, they had already started the ATT. Actually, the first thing what I would like to emphasize is the details of the patient was given to us much later. So the history, what I'm going to say, excuse me. So the history, what I'm going to say now was disclosed to us much later. So this all history was given to us not right at the initiation of ART. When the patient was given ATT when the patient was started on ART from our center, we saw that the patient was on dots from Uluberia, but the regimen was not mentioned. Later on, we found out that he was getting a weird regimen that was Cat1 dots. That time there was Cat1 and Cat2 plus rifampicin, and that was started from November 2013. It continued till May 2014 at Uluberia dots. After completion of the treatment, he came and he just showed us that, told us that the treatment has been completed. And that time we never used to start ATT from ART centers. So we had to believe. So after completion of ATT, we changed his regimen from TLE to TLM. Patient was asymptomatic and doing well. In between, due to the programmatic changes, the regimen was changed once to SLN and then again to TLE. As we were phasing out the nevirapine, we could not give nevirapine any longer. Till 2020, patient was asymptomatic to us, and patient never complained of anything in particular. In since June 2020, he started having complaints. So he was telling us that he was having backache and numbness in both his feet, and we were checking him. We were sending him to the neurology department for that. For the same complaints, he was visiting a private practitioner. So for the same complaints, he started visiting a private practitioner without informing us. There was no history given to us regarding that he was seeing somebody else. And the few investigations had been done by the private practitioner. As I have already given the details, in 2020 February, the scan showed right psoas abscess, left renal stone. Then February, the pus was taken and that was AFB positive. And RIF gene expert at MTB was also done. That also showed detected low. MRI lumbar spine was done. That shows the degeneration of the disc. But none of these were informed or disclosed to us. He was started again on ATD at Uluveria dots. He started taking, because he stayed near Howrah, he again started taking ATD from Uluveria. But he never felt like coming to us, and he thought that it's just for HIV medicines, as we were not prescribing TB medicines during that time. So after that, patient continued ATT for some time, and ATT was stopped by the doctor again for ethambutol toxicity. He was having visual disturbances, and for which he that was found to be due to ethambutol. From November 2020, the ATT was stopped and it was never restarted. Till this period, as I mentioned, the patient did not disclose all these details. And his PVL was done during that time. In 2019 also, it was within normal limit. It was later also in December also it was done. It was okay. Only in February 2021, when as per the NACO protocol, we were changing the TLE regimen to TLD, and we were vigorously asking questions about whether patients were having any TB medicines, whether they had any previous TB medicines. By then only we found out that is actually a case of bone TB who had taken incomplete treatment, and who had ethambutol toxicity as well, and who was a defaulter. So when his ATT was stopped from November 2020, we immediately consulted the chest department, and they advised the CT and USG guided aspiration from the psoas abscess, and gram stain, ZN stain, and all the CBNAT and MRI LS spine. In MRI LS spine, we found that there's a large enhancing abscess extending along the lateral margin, and there are degenerative changes as well, which was compressing the L4, L5, L5S1, the thecal sac. The FNSE also was done, and CBNAT was found to be MTB positive. The best news was that it was rifampicin sensitive. So along with the TB department, we again started modified ATD for the patient, that is INH, rifampicin, levo, and pyrazinamide from August 2021, and he started improving. Clinically, he was showing improvement, and his TB treatment completed on 24/6/2022. That's not in the history what I have given, because the patient did not complete ATT by the time I submitted this case. So now the patient has improved drastically. The patient could walk. The back pain has reduced. He's taking ART. His viral load is not detectable anymore. And luckily, we could save the patient. But I felt the need of presenting this case in December 2021, because I felt the TB relapse was not notified, or due to the unawareness of the patient, and reluctance, negligence of the patient, and the Howrah TB dots. The patient was suffering for a long time, and it could have gone into a permanent disability. But luckily, the patient is doing fine. That's how I end the case. Thank you very much.
Thank you, Dr. Prapa. This is such an important case, so well worked up. It is very rare to see a spinal TB case worked up so well. And I congratulate you for all the effort that you have put in this case. First, let me just summarize the case. Well, to summarize, the case has a very long history, and it actually is representative of all the logistic problems that we have in real life when we try to manage patients in an HIV clinic, and the problems that we saw in this case of ATT being taken from another site and ART being taken from another site, and each site missing the information about the other treatment. That actually makes a very strong case for the single window initiative that has been started since 2017 and 16 in the country. And I'm very happy that Dr. Prepa sort of highlighted this problem to us. So to summarize the case, this is a patient who comes to a ART center somewhere in 14th November 2013. That is about 10 years from now, long history, a decade old of history. And while the patient has come to them with the HIV positive patient, the patient is actually also getting treatment for TB from another source. So he is seen to have peripheral lymph nodes, all of the groups, the cervical, the axillary, and the inguinal lymph nodes, which have a histopath which is suggestive of TB. And for that, this patient has been put on category 1 dots with some additional rifampicin for some reason, maybe probably the weight. But because the history is a gray area here, we are not sure what was given to the patient along with category 1. From 22 November to May of 2014. Now, very appropriately, the patient also was started on ART, even though they did not know about the history of TB. Somehow it worked out very well. And 2nd December 2013, that is about 12 days after starting of ATT, the patient was started on ART TLE. The patient had good adherence and he was doing well. He completes his ATT for this particular episode. Because we were not the people managing TB, because we didn't have any information of TB, so the TB treatment was not monitored. We did not declare any outcome. We do not know what happened to the peripheral lymph nodes in that particular episode. But yes, a complete course was taken of 6 months, and the patient was well for 6 years. 6 years, the patient is well. He keeps on taking whatever is the program prescribed ART. It is changed from time to time. The patient keeps taking that. Then again, after 6 years, from 2014, when he finished his last episode of his last dose of ATT, in 2020 June, he starts complaining of some backache and numbness in his feet. Now, again, this ATT, and this patient probably goes back to his earlier doctor or to some other doctor outside the HIV system, where he is diagnosed as spinal TB, which is proven by an MRI. And there is also, I think, there is a aspirate from the right Psoas Abscess, which shows that MTB is detected. Outside the ART system, the patient is again started on category 1 on 21 February 2020. Okay, but this treatment is only given till 11/11/2020. It is given for 8.5 months, but not the entire duration that you have to give for spinal TB, which is at least 12 months. And it is stopped after 8.5 months, saying that it is ethambutol toxicity based on the fact that the patient had some loss of vision or dullness of vision. There was no test carried out by the TB physician to see whether it was actually a ethambutol toxicity or whether it was just a visual acuity problem or some other problem. However, it was empirically stopped. We would appreciate the fact that if you cannot get an ophthalmological examination to know whether it is ethambutol eye toxicity, it is better to stop, because ethambutol toxicity is an irreversible toxicity. And once it sets in, there is no way of reversing it, but it is a better practice to actually get, if the patient complains of diminution of vision, it's a better practice to get an ophthalmological test done. And then based on that, you take a decision to stop or to continue ethambutol. Anyway, this was done, and I think 8.5 months patient was treated. And throughout this period, the patient kept on taking his ART so that his viral loads were always target not detectable. Then in June 2021, the ART Center, when they took a stringent history for other reasons, they found out that actually this patient had not disclosed about his previous 2 anti-TB histories. And this time when they saw the patient, this time actually his anti-TB symptoms had exacerbated. On the MRI, you could see that the Psoas abscess had become bigger. And from the right side, it had also gone on to the left side. So now that it was compressing the cord, and ideally, if God had not been very kind to this patient should have had symptoms of cord compression. But somehow God was kind and he did not have paraparesis. The patient's also the spinal destruction from where the Psoas abscess was tracking. That was in the earlier case, it was only L3, L4. But now it was L4, L5, and S1. So the spinal destruction has also increased because probably the treatment that was given to the patient earlier was incomplete for a lesser duration than required. This time also a CBNAT was done and MTB was detected and RIP was sensitive, which was very good news. Because of the question of ethambutol toxicity, the patient was started on rifampicin, INH, levofloxacin, and pyrazinamide on, I think this is it August of 21? Yeah, started on August of 21 and given till April of 22. So now the patient is symptomatically better, is doing well, and he continues to be on the appropriate ART as per the program and as per his condition. So with these comments and this summarization of the case, can I request our team to please pull up the pretest questionnaire? And in the meantime, it also gives us an opportunity for anyone from the house to ask us any questions, to seek any clarification, to make a comment before we go on for the expert comments and the expert presentation of our TB specialist today. And with this, I would request Dr. Lokender, our TB specialist for the day, to give his expert presentation and his expert comments on the case so that all of us can learn from him. Dr. Lokender, over to you.
Thank you, Dr. Upasna and your team. And I'm highly obliged invited me to discuss this case. So, good afternoon, all of you. So, based on your case and what I found, the reason for the case presentation is relapse of TB due to reluctance and negligence of patient, delay in disclosure of TB diagnosis, and ATT-induced toxicity lead to inadequate treatment, permanent damage, and worsen the prognosis. Based on this, I made my presentation is next. Is the management of the management of drug sensitive extrapulmonary tuberculosis. Myself is Dr. Lokender from NITRD. Next. Before starting my talk, I just want to highlight the extrapulmonary tuberculosis burden is 16% of 7.5 million reported TB cases globally and 19 in Southeast Asia. Although the considerable proportion remain undiagnosed or not notified. Next. So when we talk about the extrapulmonary tuberculosis, one should understand what is presumptive extrapulmonary tuberculosis. That is, organ-specific sign and symptoms like swelling of the throat, which we our case have, pain and swelling joint and neck stiffness, disorientation, etc., and or constitutional symptoms like significant weight loss, persistent fever for 2 weeks, and night sweats. Because we are dealing with the spine TB, there are certain things which we can suspect that it could be a case of spine TB. It is persistent localized back pain, which our case has. Spinal tenderness, spinal cord compression might be there because it says there is a numbness of the patient, and fever and weight loss. When we classify for the anatomical site of the disease, we could say this could be a case of extrapulmonary tuberculosis. Means refer to any microbiological confirmed or clinical diagnosed TB involving organ other than lung is extrapulmonary tuberculosis like pleura, lymph node, intestine, GI, spine, bone, meningitis, etc. Next. What I could collect from your case presentation? What I understand is the patient developed tubercular lymph node in November 13 and he took ATT till May 14. It means he took 6 month anti-tubercular treatment and your outcome would be completed. Clear? After the gap of 6 years, spine TB and tubercular Psoas Abscess developed and turned out to be AFB positive. Now this case become a recurrent tuberculosis. After ATT was started with effect of February bis till November, approximate 8 to 9 months only, and he left because of the ethambutol toxicity. Now your patient turned out to be defaulter. But why? I will discuss in next slide after a few slides. Why he was defaulter even after taking 9-month treatment. After the gap of 7 months, again he developed the symptoms and CB0 was sent and turned out to be positive. Now your case become left follow. Left to follow. Lost to follow. But he is on treatment as per your case shows. He is still continuing the ATT and showing improvement clinically. It's good. Here I have a query. When he start modify ATT, anti-tubercular treatment means INH repentancy vivo. I have put a query over there. I'll answer later on. And paradigm. Next. So our case, what is the definition of our case? But it comes under the previously treated TB. In under that heading, we had a recurrent TB, which we have treatment after loss to follow, which we have. What is recurrent tuberculosis TB is the TB patient previously declared as successfully treated, cured or treatment completed, which he has already completed in 2013-14 for lymph node and is subsequently found to microbiological confirmed. It means it become recurrent because of Psoas Abscess was positive for AFB. But after 7 or 8 months, he left the treatment because of the side effect of levofloxacin, ethambutol. Now he become treatment after loss to follow. A TB patient previously treated for TB for 1 month or more and was declared loss to follow on their most recent course treatment and subsequently found to be microbiological confirmed TB. As you know the history, last time again he was become a microbiologically positive TB in the Psoas Abscess. So now it become after 7 months he took the treatment, then he left. Now he become lost to follow case under the heading of past history of ATT. Next. Now, how you can diagnose a case of extrapulmonary tuberculosis? There are so many procedure is there, but in our case, we had done the fine needle aspiration cytology for lymph node and fluid. Means pus was sent for cytology and it turned out to be positive. Next. As per all that, our case is microbiologically confirmed TB. Presumptive TB based with biological specimen positive for AFB or positive for MTB on culture or positive. Our cases also has a confirmed case because it turned out to be microbiologically confirmed TB positive with rifampicin sensitive. Next. Now we want to treat. We certainly have a goal and objective of treatment on scientific basis of treatment. What are the goals? We want to render patient to non-infectious, want to break the chain of transmission and decrease the pool of infection. Same time, we want to decrease the fatality, morbidity, or by ensuring the relapse-free cure and want to minimize the prevent development of drug resistance. And then when we start the treatment, what is the scientific basis of treatment TB? There are 4 criteria. Domiciliary treatment, as effective as sanitary treatment. So we are starting the domiciliary treatment. Short course chemotherapy is already 6-month therapy with RH or pyrogenamide is known as short course treatment. Most important over here is the treatment regimen. Is what the basis of chemotherapy, bacteriological basis, pharmacological basis, and daily. And DOTS study in India and many other countries, 1/3 of the patients do not consume medicine regularly. That's why DOT was introduced. Next. As I talk about the bacteriological basis of anti-tubercular treatment, they have 3 actions: ugly bactericidal activity, sterilizing activity, ability to prevent emergence of drug resistance. As you can see, INH and pyrogenamide have all 3 activities. Streptomycin did not have sterilizing effect. Although pyrogenamide have activities, but lesser than the rifampicin and INH. Ethambutol is the least bactericidal sterilizer, and it also less prevent the emergence of drug resistance. Next. When we talk about the pharmacological basis of treatment, we want to achieve the peak serum level of all the drug so that we can maximize the bactericidal effect over time. That's why, if you are, all of you must be knowing that the physician used to say that all the medicine has to consume at once. So the meaning was we want to achieve the peak serum level of that medicine. And we have started the daily regimen because at the alternate treatment or intermittent treatment, we found the relapse rate were higher. But ADR with daily regimen may be higher compared to this. That's why daily regimen is converted from intermittent treatment to daily regimen. Next. So, how you can treat the extrapulmonary tuberculosis with reference to ARTC? Regimen for extrapulmonary tuberculosis is clear. 2 HREZ followed by 4 months HRE. And we have divided into IP phase and CP phase. The total drug is 56 dose or 1 month 2 days. In the below, you are seeing the bone and joint TB and spinal TB. The duration of treatment for tuberculosis is 12 to 18 months. This is national guidelines says. And our patient in second time, he left ATT after 9 months. That's why you are able to say the defaulter. Otherwise, you can't say the defaulter because he has taken the 6 months or more. Because the spinal TB required 12 to 18 months treatment. That's why we are able to say default. Okay, next. So although there are so many literature is there which says the 6 month, 9 month, 18 month treatment for spinal TB or bone TB is more than sufficient. Even the third 3 centers 6 to 9 months found excellent response by 5-year follow-up. Recent trial from India patient with biopsy spinal TB and treatment for 6 to 12 months ATT, and they have a similar clinical outcome at the 24th month of completion. What does it mean? It means the literature is also if you given a treatment for 6 to 9 months for bone TB or spinal TB, it is more than sufficient. But the people from orthopedics, they did not agree. So that the national guideline is continue with the advice of orthopedics physician or orthopedics doctors. Next. The question arises, why we have an IP and continuation phase? The role of IP is, its objective is to achieve rapid killing of actively multiplying bacillary population, also eliminate the naturally occurring drug-resistant mutant, and to prevent the further emergence of drug-resistant mutant. Then what is the role of continuation phase? The CP role is the elimination of persistor which are responsible for the relapse. The CP may be extended up to 12 to 24, like in CNS, which we are doing already doing scalping TB or descent. We are doing for extended. That's why we have a 12-month or 18-month for specific condition where we are extending the extrapulmonary tuberculosis. Next. So this is the schedule as per body weight. All of you know, I'm skipping this slide. So finally, what is the management? Management of extrapulmonary tuberculosis, the same. But ATT may be extended by 3 to 6 months in special situation like TB meningitis, bone joint TB, spinal TB with neurological involvement and neurotuberculosis. Unless drug resistance is suspected, adjuvant corticosteroid treatment is recommended for TB meningitis and pericarditis. Next. Now, next part is the side effect. All anti-tubercle treatment have side effects. Main side effect and trigger. And we will talk about the ethambutol because our case is having a problem with the ethambutol. As you can see, ethambutol had retroverbal neuritis. Okay, so our patient is also developed a visual problem. So here we have to send to the ophthalmologist, but we did not send, or either we do not have any report or any information about the opinion of ophthalmologist. Next. So before we start saying that anti-tubercular treatment, ethambutol is the main culprit to change the anti-tubercular treatment or modify anti-tubercular treatment. So what we talk about the ethambutol, what is the contraindication? Contraindication if you have a false hypersensitivity or optic neuritis. We have two precautions. It should be discontinued at the earliest symptom of impaired vision or deranged perception of color. What is after adverse effect? Dose-dependent optic neuritis may be diminished visual acuity and impaired color vision. Early change of visual acuity are reversible, but sign of peripheral neuritis may manifest in the lens. Peripheral neuritis may manifest the as you also mentioned the numbness. So I told you once I show you the modified anti-tubercular treatment, I make a query or I put a question mark over levofloxacin. I put it because as per our guideline, streptomycin is administered only in certain situations like TB meningitis, or if any first line drug need to be replaced due to ADR as per weight of patient. But in our case, we replace by levofloxacin, whereas guideline says streptomycin. Although moxifloxacin is the first line agent when administration in combination with the INH rifampicin and pyrazinamide, that is from up to date. Debate may be there, levofloxacin is better or moxi. It's a hardly debate. But thing is, the first drug of choice was streptomycin, which still is not eliminated from the guideline. So we could start the streptomycin beside the levofloxacin. Next. So management of ADR is depends the dose of drug should be checked. All other cause of symptoms should be excluded. The seriousness of adverse effect should be estimated. The adverse effect should be registered. The drug may be stopped and reintroduced not only for ethambutol, all the first line medicine. That is for all the first line medicine, the drug may be stopped if you have an ADR and you are think that should be stopped. The drug may be stopped and reintroduced gradually when symptoms disappear. And we have to see the development of the medicine should be out. Next. So take home message is regimen for drug sensitive extrapulmonary 2-HRZE followed by 4 months HRE, except few cases like TB meningitis OTB, spinal TB. IP, intensive phase and continuation phase has role in management of TB. ADR is to be managed accordingly. The management of TB in special situations is possible. Streptomycin is administration only in certain situations. This is the only drug of choice when ADR is appear. You can discuss the moxie versus levofloxacin, which one is the best. Once you are not able to start streptomycin in combination of amitriptyline, guanidine, and pyruvate. With this, I think next. Thank you very much for pushing it. And that is all related to your case. You know, your case says outcome completed. Your case says recurrent of anti-tubercular treatment. Your case says I am a defaulter. Your case says I am lost to follow. Your case says you can modify my ATT. After modifying my ATT, I am improving. But despite of starting levofloxacin, you can think of streptomycin first. If you are not able to give them a streptomycin, then only you can think of chloroquine. That's all. Thank you.
Thank you, Dr. Lokender. That was really very, very useful. I think a very simply presented talk about the case. Does the House have any questions before I actually summarize Dr. Lokender's presentation? So while you're thinking of questions and answers, I think I would like to start summarizing the case. Well, as Dr. Lokender said, he has been explaining it very beautifully that this case had several problems, not problems as such any from the medical team or anything, but generally this case covered various aspects of TB treatment, right from the definitions to what kind of treatment is required, for how long it is required, and if there is a ADR, then what is to be replaced. So as Dr. Look, I'll just summarize now in a few points. It won't be an exhaustive summary. It will be only a summary of the main points that need to be highlighted. Well, what Dr. Lokender told us that initially when the patient was diagnosed as TB, and if there was no past history of TB, then he was probably given CAT1. Then he was a new case of TB. But after the first episode of TB, which was completed in 6 months and successful outcome was there, the patient again had TB after 6 years, and this was a microbiologically confirmed TB. So this particular episode of TB becomes a recurrent TB episode, and recurrent TB episode is actually a subgroup of the bigger group, which is a previously treated TB. Previously treated TB has two subgroups. One is recurrent TB. Recurrent TB means that you have successfully treated TB in the past with a complete course of anti-tubercular therapy, and now the patient has again developed a microbiologically confirmed active TB. While the other category is treatment after loss to follow-up. So, जिसको हम पहले treatment after default बोलते थे.
What Dr. Upasna is saying, what I have shown for with reference to our case only. Otherwise, one category is also failure.
Yeah. So one case is also failure in which the patient actually doesn't respond even the first time, even that particular episode. So for our case, there is also something known as TAD, जिसको हम पहले treatment after default बोलते थे. Now it is called treatment after loss to follow-up. In those particular cases, you get a fresh episode of TB after successful completion of your previous episode of TB. After unsuccessfully being treated for TB. That means your first episode of TB was not completed successfully. It had been left in between for any reason, patient reason, medical reason, side effects, for whatever reason. That first episode of TB could not be completed its treatment, and now after certain gap of time the patient has come back with another episode of TB, and this time the patient is microbiologically positive. So this is known as treatment after default. So if the patient has been successfully completed earlier and then he comes back with an MTB positive report, then he is recurrent TB. If it doesn't have successful treatment in the first episode, comes back with an MTB positive report TB, then it is treatment after default. So in our particular episode, as Dr. Lokender told us, that the first episode was probably new TB, the second episode was recurrent TB, and the third episode was treatment after loss to follow-up. So this is how we would define the episodes of TB that have taken place. The other thing that he told us was about ATT in general. He gave us the scientific facts. In the scientific facts, he said that why do we do directly observed therapy? The reason for doing directly observed therapy, or directly observed therapy, is a term. It doesn't mean that it doesn't mean that you are watching every pill being swallowed, but it is a way of observing the adherence. So that now DOTS has become a broader term, and DOTS basically was started because it was seen that 1/3 of the people who were prescribed ATT, they would not take their drugs if left to themselves. So DOTS is an important component of our program, and we always give a combination of drugs because every drug has its strength and it's not so powerful strengths. So like the drugs you can have an early bactericidal activity in which INH has a maximum bactericidal activity. Then there is something known as a sterilizing activity in which rifampicin has the max. Then there is something known as prevention of drug resistance, for which we use a combination therapy, and pyrazinamide is one such anti-tubercular therapy which has all three kinds of active functions. The other thing that Dr. Lokender told us was that we have now started giving daily regimen instead of alternate day regimen, because a daily regimen is shown to have better results as far as relapses are concerned. He also told us then about this particular case in which he explained that a Psoas abscess, or for that matter, any abscess, any cold abscess, it could be in the psoas muscle, or it could be up in the chest, or it could be in the nape of the neck. Any cold abscess basically means a spinal TB. So when it means spinal TB, it means it is a skeletal TB, a bone and skeleton TB. So now this TB, even if only an abscess is visible, because sometimes only an abscess is visible either by the eyes or even on CT, sometimes you might only see an abscess. You might not be able to see from which vertebra it is coming. Sometimes it happens, it's quite common. But whenever you see a cold abscess, whether in the psoas or any other muscle vein, it is a spinal TB. A spinal TB means a bone TB. And a bone TB, why do we need to do that? We need to do for assessing the correct duration of therapy. So as far as the duration is concerned, Dr. Lokender also told us that as per our index guidelines on the guidance of evidence and the guidance of our orthopedic surgeons, it has been decided that for spinal TBs, you will give treatment for 12 to 18 months, 12 months at first instance. And then in a follow-up of an orthopedic surgeon, if they want to extend it for 6 months more, you can actually give it for a duration of 18 months more. Though there is some literature that says that probably 9 months are also as effective, but the expert opinion says that we should at least give for 12 months, extendable to 18 months. This 12 to 18 months duration is also there seen for CNS TB and other neural TB and even joint TB. Not only bone TB, it is also for joint TB. So the other thing that he told us about was, why do we give it in IP and CP? We give 4 drugs in IP because we want a combined effect for rapid killing of active multiplying cells. So we can also not only bring the disease under control fast, we can also eliminate natural DR mutants and prevent emergence of further resistance that would happen if we do not act this fast. And CP is obviously there to consolidate whatever we have done in the first 2 months and also preventing relapses. Another point he emphasized was that please give ATT according to body weight. By giving sub-therapeutic levels, all that we do is we worsen the prognosis of the patient and probably make him drug resistant also. The side effect of the first-line ATT drug that was also a concern in this particular case was ethambutol-induced optic neuritis. And optic neuritis and peripheral neuritis is probably the same width of the neurofiber. And it is important to understand that if the patient has peripheral neuritis, you should also look for optic neuritis. There is a decrease of peripheral vision, and there is also some color vision abnormalities, which are better if checked by an ophthalmologist. For management of ADRs, sir told us that please ensure that the dose of the drug is normal. Sometimes people tend to get overboard and give much higher drugs than is required by the body weight. So please do not give higher doses. Give the correct dose. Don't give it low, don't give it high, give the correct dose. Higher doses will always lead to increased side effects. So there's a doses of drugs which you should confirm and which you could probably play upon if you are having side effects. You should look for all other non-drug related causes for the symptoms. You should assess the seriousness of the side effect, and the assay is to be registered in the pharmacovigilance program of the country, and the drug has to be maybe stopped, then you get a side effect, and reintroduced gradually when symptoms are gone, and you can avoid correct management of SAEs leads to prevention of drug resistance, because if you have side effects and you don't manage them properly, then you tend, either the patient tends to stop taking the drugs, or you are giving subtherapeutic drugs, or you are giving lesser drugs than required. So that is one of the problems that you can have if you do not manage and pick up the side effects in timely manner. The last very important point that Dr. Lokender told us was that which drug to give if the patient cannot be given any one of the RHZEs. So as per the current guidelines, if we have to replace any drug in the RHZE category 1 regimen, it should be streptomycin. Streptomycin is not only a replacement drug for one of the first line drugs, it is also a drug of choice for meningeal and CNS TBs. But there is evidence to suggest that if for some reason you cannot give streptomycin, there are always availability problems of streptomycin now, then you could probably use a levofloxacin. But if you have to shift the patient to a levofloxacin based first line anti-tubercular therapy, I would request you to do it in consultation with a TB expert, because preserving future options in case the patient develops resistant TB is also very, very important. You have to understand that fluoroquinolone is a very, very important second line drug. And if we use it in the first line and God forbid this patient lands up in a MDR TB situation 2 or 3 years down the line, then we would have actually wasted a drug in the first line, which would have been very useful in the second line. So these were the major comments from Dr. Lokender. And just to add to that, I would request all of you that we have also discussed spinal TB in a presentation in June 22. In June 22 by Dr. Adityanath Agarwal. We are just sending the link to that session in the chat box. I would request all of you to go through that presentation again, because that was a very good and comprehensive review by an orthopedic surgeon. So please go ahead, and I encourage you to use this link. Just a minute. In which Dr. Adityanath actually emphasized that apart from giving ATT for the correct duration and the correct doses and the correct combination, spinal TB would require certain adjuvant therapy like braces. The patient should be asked to wear a brace if resources are available. The vitamin D should be added to his drug regimen, some calcium, a good diet, physiotherapy if mobilization is not risking a paraparesis. So if there is no risk of paraparesis, then mobilization of the patient only under the guidance of a physiotherapist. And the other thing that you can do is, in case the spine is too unstable, like the patient has developed paraparesis recently, or his spine is too unstable, then you should refer to an orthopedic surgeon for stabilizing the spine by surgical methods. And the very last thing that could happen in a patient could be a deformity, a kyphotic deformity, which can also be corrected by an orthopedic surgeon after completion of the anti-tubercular therapy. So this would be the summarization of the case. Dr. Prapa, would you want to ask any more questions, or is your problem, are your questions answered?
Yes, I'd like to ask something that in our daily practice scenario, whenever we find a patient with NTD-induced hepatitis or a prior existing liver issues like CLD or hepatitis B or C, we usually start and along with the co-infected with TB, so we start the patient on modified regimen. Most of the times we give streptomycin, levofloxacin, and ethambutol. And later on, when the patient is improving, we re-challenge with each of the ATT drugs. And if the scenario is better and patient's reports are showing reports are showing normality, and then we shift them back to the 3-FDC or 4-FDC. Usually, we avoid pyrazinamide in a case of ATT-induced hepatitis. But as you said, that it's important that we save levofloxacin, because we can find few cases who are coming to us with MDR. We have patients who are MDR and who have been treated accordingly. That those medicines, we don't keep MDR medicines. But in that case, if you are not giving levofloxacin, then what should be the regimen for modified ATD generally?
Yeah, so that's actually a very, very important question. And as I understand, for managing liver toxicity, there's an entire algorithm about when to stop, how to restart, what happens, what not to stop. And I will just request Dr. Lokender, can he answer your question
Yeah.
in brief? In brief.
In brief, once you have a deranged LFT, first thing is, before starting anti-tuberculosis treatment, you must have a liver function test, number one. And to rule out, previously he did not have any chronic liver disease. These are the two scenarios. One is a normal liver, second is the disease liver. Once patient is suffering from the disease liver already, then you have to give the modified ATT. If liver is normal, LFT is normal, you start with the normal anti-tuberculosis treatment or drug. At the same time, if your patient develop hepatitis, gastritis or hepatitis, then you have to act accordingly. What is that? That is, you can stop all the ATT and you can reintroduce one by one. Okay, and wait for, or you stop the ATT, wait for 5 to 6 months to become a normal of the patient and reintroduce. If you reintroduce the medicine again, if LFT is deranged, then you can add one by one. If you have a guideline, that NTP and NTEP guideline, they have a very clear cut mention. They have mentioned everything that in special situation what to do, what to do. And for the liver function, they also have the same.
So, Dr. Prapa, we would like, where we do the recommendations of this case, we will send you the algorithm also for ATT management.
Special
And
situation.
the special situation one, and which we do it for hepatotoxicity, how it is supposed to be done. This algorithm is actually universal. It's not only the algorithm that is given in the anti-TB guidelines of India, these are also available in every anti-TB guidelines of the world. That is a common algorithm. And we would like to share that with you. Okay? Like, guidelines.
Rather starting the modified ATT, you can wait for to normalize the liver function test if it because of the drug use.
I just have one doubt, that can't we continue with the modified ATT? We usually stop the ART till LFT settles down, but we continue with the modified ATT because we don't want to stop the TB treatment abruptly. But if it's not if it's not an abnormal range, definitely. If it's mildly high, the reports are mildly deranged, then we continue with the modified ATT. But is it correct approach I need to do?
No. As per guideline, you have to reintroduce all first line medicine, not modify ATT. You may start modify ATT once you establish this is the case of already liver disease or liver disease is established. Then only you can start a modify ATT. Otherwise, you have to reintroduce our first line medicine, whatever reason is there. But once LFT drug induced LFT is there, you have to restart or reintroduce the first line medicine.
So, what I would like to inform you, Dr. Prapa, there's actually what the general physician does and what the TB guidelines say. There's a little difference in what we perceive as general physicians. I'm also a general physician. what we perceive as what we should do in TB and what is the guideline. So when we send out the recommendations for this particular case, we will also send out that particular that algorithm for especially for hepatotoxicity. And we can request you from this platform. All we can do is request you to probably follow that in future, because it is similar to what we do for ART. Like we would not use a protease inhibitor in the first line. Similar, and if for some reason the patient is allergic to any one of the drugs that is there in the first line, we would, if they have a side effect, we first stop, we try to reintroduce, we try symptomatic management, and we try to reintroduce with symptomatic management. If that doesn't work, we try to desensitize, because we do not want to use something that is reserved for resistant cases in the first line. And it has been number one. And number two, there are ways by which we can make the patient adjust to the original regimen. So if we walk those steps, then probably that is true for ART also. So similarly, it is for ATT. And it is just the reason why we do these clinics, so that we can probably impart that information to you. And I'm very, very thankful that you asked this question from us today. We will send out that algorithm and probably try to have a case of ATT-induced hepatotoxicity in a person living with HIV as soon as possible in this forum. What the rest of the questions answered? Yeah, are you okay? Anything else anybody wants to say from the audience? So now we request you to attempt the post test, and I hand over the mic to Dr. Jyoti to finish the session. Thank you so much.
Now I would tell you the correct answer for question A. The treatment regime for the spinal TB is option C, 12 to 18 months. And the correct answer for question 2 is option B, streptomycin. Thank you so very much. And we have also shared the feedback link in your chat box. I would request you all to please give your feedback. It is essential for us to analyze the quality of the sessions.